Dr. Ed Mikol, I'm one of the founding partners here, and I wanted to talk a little bit tonight about sports-related injuries of the shoulder and the upper extremity. And now I'm trying to gear this a little bit more toward our region and our area. And so I'll spend some time on some of the things we're more likely to see here versus, let's say, little leagues in the middle of Charlotte or something along those lines. I see some familiar faces. Welcome, everybody. So we'll start off with the shoulder, work our way down toward the fingers. And the main thing, the biggest thing that we're going to see around in this area is going to be rotator cuff pathology. So I'll spend probably the most time on that. But other things such as instability issues with the shoulder, biceps tendon issues, and then some specific throwing injuries if those of you who may be playing softball or have friends, family that are in sports that involve throwing. These will be a little bit more geared that way. So we'd be talking more about this lady over here raising her arm up with this sport injury, not the guy getting hit with the bat. So a little bit of shoulder anatomy first. There are basically three main bones about the shoulder. The shoulder blade, called the scapula, the humerus, and then the clavicle up top. Around that, there's some important structures. The rotator cuff being this muscle part. There's four muscles, but this particular one is called the supraspinatus. And as it comes out, it's going to attach to the bone here. And so when we talk about rotator cuff injuries or tears, that's what we're talking about, damage to this structure here. But there are other things that can occur in the shoulder, such as what we call labral tears. This little structure right here is called the glenoid labrum, and that can be torn. That can get caught, or it can be torn and be loose and result in some instability about the shoulder. And so we'll get into these things a little bit. So since this is a throwing injuries or a sports injuries, an overhand throwing is a very, very, very complex and traumatic mechanism in the shoulder. The main phases have been broken down, and the two that in particular we're really interested in is what we call late cocking and acceleration, and then also follow through. So during late cocking, when your arm is back and you're getting ready to come forward, that gives you a lot of rotation on the shoulder, and that stretches a lot of the ligaments in the front of the shoulder. As you get more proficient in pitching, a lot of times you'll get more external rotation. That's a common thing you'll see in baseball pitchers. Well, that gives you a little bit more speed on the ball, but it also stresses the structures in front of the shoulder, which we'll get into a little bit, while allowing the ones in the back to be tight. And as you follow through, you have to decelerate that arm. So you're talking about different sets of muscles now that are going to slow down your elbow, slow down your shoulder, and that puts yet different stresses on different parts of your shoulder. But it's been studied over and over and over again, and more understanding of the throwing mechanism is the rotator cuff holds the ball and socket together dynamically. There's ligaments that hold it together. Those are so-called static restraints. But the rotator cuff here counteracts the pull of the deltoid. This would be the deltoid muscle, which tends to want to ride your shoulder upwards when you contract it. And then these muscles keep the ball and socket together so it doesn't shift around in there. And when they get weakened or damaged or torn, that is when you start to see rotator cuff symptoms and pathology. So the symptoms of a rotator cuff injury is pain often in this area that runs down the arm. You'll have it that generally it doesn't run below the elbow, but it's usually not up all the way up near the shoulder. It runs down here, and patients are always telling me, but it hurts here, why are you injecting up here? Well, that is the way the body's wired. You might have pain with lifting of your arm, pain at rest, pain at night when you're sleeping. You may have some weakness, but you might not, or you might not even have symptoms. I see a lot of people with what I would call end-stage rotator cuff tears that said, it never bothered me before, and I'm looking at a rotator cuff that's been torn for many years, and in fact, you can't even repair it on some of these. So the rotator cuff examination, guarding is when you don't let somebody move your shoulder. It hurts and you want to just keep it there, so you won't let me or even yourself use it. Pain with motion is one of the symptoms. Crepitus is a crunching sound that not always but generally can be problematic. Sometimes it's not something to worry about. I get that in my shoulder. It doesn't usually bother me too much. Weakness, of course, and what this is called is an impingement sign. You may get a little mad at me when I examine you, but I will purposely try to make you hurt doing that to confirm that that's what you have. So I try not to do it too hard, but hopefully you won't be too upset if I do it. Usually save that for last. So impingement is shown right here. What you have is a compression point where the bursa, the fluid-filled sac that allows these two structures to glide on each other, the humeral head and the acromion, there's a tunnel in there, and that rotator cuff and bursa has to slide around in there. And if that gets pinched or tight, that's when you start to get the pain. Either bursa can get inflamed, that's called bursitis, and that's shown right here, where the bursa is inflamed. Or you can get a tendonitis where the tendon's inflamed and irritated. Or quite frankly, you can get a rotator cuff tear, which this shows. It can be a partial tear, and a lot of people will come to me and say, I'm told I have a rotator cuff tear. And technically you do if it's a partial tear, but the rotator cuff's made up of a lot of fibers. Think of a rope that's fraying, and if a few fibers are gone, that may not be that important, although it can be, but it's not the same as having a complete hole in your rotator cuff. So it doesn't always have to be addressed with surgery. An example of an MRI, further investigation of a rotator cuff, will allow you to show the actual muscle here with a tendon that's coming out to the end of the bone and right in here. This tendon should be black and thick like this, and this one is inflamed and irritated. It has fluid in it, and that's what this is trying to show, rotator cuff tendonitis. And over here you can see a frank tear. It's pretty obvious that this black structure here does not attach to that. That is a rotator cuff tear. This one is not particularly retracted or particularly large, but it is a tear. So in the majority of patients, if it's not torn, you can treat people with an injection if they've got things like bursitis or tendonitis. And certain people who do not have a rotator cuff that's repairable, we might recommend conservative care if they can get by with it. But if you do have a rotator cuff tear, or if you fail treatment of the tendonitis, we may end up having to do surgery on you and repair the rotator cuff. So what are the non-operative treatments? Well, you try to avoid the behaviors that are actually irritating your shoulder, so-called irritants. Whatever those behaviors might be, or the particular exercise, doesn't mean you can't ever do it again, but if we can get your symptoms under control, get the pain down, get the swelling down, you might be able to go back to them. Anti-inflammatory medicines, Motrin, ibuprofen, Aleve, Advil, that kind of stuff can help. An exercise program is very important, whether it's at home or physical therapy. It can be very important and help you on your way to recovery with rotator cuff issues. And then, of course, injections, that you'll see me do a lot of that here. It tends to help. The steroid medicines and anti-inflammatory will decrease your pain and discomfort. It has a numbing medicine that works right away, gives us some feedback. But sometimes these fail. In the exercise program, you want to be able to stretch the shoulder joint capsule. Sometimes the front or the back might get tight, generally the back, or in the bottom part of the rotator cuff, the joint capsule can get tight, and sort of squeeze the ball up higher, decreasing the space between the acromion above and the humeral head, resulting in rotator cuff pathology. So stretching is important, also strengthening of the rotator cuff. If you fail non-operative treatment, we may perform arthroscopy, where we make a few little holes in your shoulder and we introduce a camera, a fiber optic camera. We fill your shoulder up with fluid, pressurizes it so we can get around in there and see. And there are several things that we can treat with that. If you have what we call rotator cuff tendonitis or impingement, we might do a decompression where we trim the bone above the rotator cuff to open up the space. So something that's tight, rubbing like this, might now be like this, where it doesn't rub. And that might be enough to get you taken care of. This would be removing the spur on the far right there. We can convert these different types of acromions. One on type 3 there has a hook that sticks down, and when you lift your arm up, that hook can bang into the rotator cuff, and if you remove it, you've got space to move now without irritating the rotator cuff. If you have a tear, this is one method of repairing, probably not the most up-to-date for how I do it, but it is an arthroscopic repair where we grind down the bone in the upper left there. We pass sutures through the rotator cuff, and these little anchors are put into your shoulder, and the sutures kind of pull pull the rotator cuff over and hold it into position and allow it to heal. That will require you to be in a sling, and people hate that. I'll just keep repeating that because it's not fun to be immobilized for 6 weeks in a sling. If any of you have had that, you'll know what I'm talking about, but that's the worst part about going through the surgery, I believe. So here's a normal rotator cuff from below. That tendon is coming down and attaching to the bone right here. This one over here is a partial tear. You can see some of those fibers are torn off, but you can't see through that all the way. The one on the lower part of the slide is all the way through. That's a complete tear of the rotator cuff. This needs to be fixed, and then this one particularly is what we call a high-grade tear, so probably more than half of the thickness of the rotator cuff is torn, and that will need to be repaired. But some of the smaller ones where 10, 15%, we might not have to repair it. We could just clean up the torn fibers and let it heal. A decompression might also require a bursectomy. Above here is the acromion, down below here is the top part of the rotator cuff. And all this space here is now cleared out from what was in there when we first went in. This is bursitis. That's irritated, inflamed tissue. You can see it's red, it's got a lot of blood flow because it's irritated and the body's trying to heal it, but it's not healing. And so that's an angry shoulder that needs to be cleaned out. Now we try to fix that with steroids, of course, with a shot. That's where we put the shots, but sometimes it doesn't work as it did in this patient. A bone spur here, it sticks down and can pinch this rotator cuff, and on the right we've removed that. So the gap is pretty large in here now where it used to be a bone spur that sticks down. And then here's an example of a rotator cuff tear, a crescent-shaped tear that is repaired with sutures. This is probably a little bit of an older technique, but same basic idea. So a sling for comfort, if we don't repair your rotator cuff, you can come out of the sling right away. But if we do have to repair it, you're going to be 6 weeks in a sling. It's going to involve a fair amount of time to recover from this kind of a surgery. But we will start you on motion exercises early and then strengthening when the appropriate protocol time has arrived. And generally, that's going to be about 6 weeks. Some tears are bigger than others, and we may go slower. Some tears are a little smaller, may go a little quicker. And I'll move on a little bit now into what we call shoulder instability. So the shoulder is a ball in the socket. And everybody knows the shoulder can dislocate, pop out of joint. So that's when the ball rides over the socket and pops out. Subluxation is where it slides maybe to the edge of the socket and pops back in. There's different categories, but let's just grossly call it that. It shifts out, and people can feel it shifting around, or maybe not even feel it, but it hurts when they do things like throwing, particularly when your arm's up and you're coming, when it's way back here and you start to come forward, it might slide. And generally, a subluxation is an attritional thing where somebody is, let's say, a pitcher, and they repetitively injure that and stretch that tissue that holds the shoulder in place, and then eventually it might get worse and worse and eventually can dislocate. But dislocations often are a traumatic event. That may not be a sports injury, it could happen just by falling, but it happens frequently in sports, where your arm is forced into a position that stretches the ligaments and levers the shoulder out, and this bottom picture shows you the shoulder out of the socket. And there is some damage to other structures sometimes, such as this is where the shoulder is fractured in the back. That's called a Hill-Sachs lesion. And you see people sometimes who dislocate, and as you get older, your bones are weaker. You may dislocate and you may shatter your shoulder, and I'm not going to address that here, but that could even require a shoulder replacement surgery for something along those lines. So symptoms of subluxation would be popping, locking, your shoulder might grind when you move it, or when you throw, you might have pain. And with pitchers, decreased velocity. They may notice that they can't throw as hard or as fast or as far for an outfielder, let's say, as they used to. And they can sometimes feel it that it wants to come out of socket. Dislocations and subluxations can have associated injuries such as tears of this labrum. The labrum is the structure that goes all the way around the shoulder here, and this is a torn labrum. But you can also have fractures, as we showed you, rotator cuff injuries, and tearing of the ligaments, and we'll get into some other things in a little bit here. So dislocation, if a shoulder dislocates, there's no missing it. It's out, and you'll know it's out. And that has to be reduced, we call it, where you do a closed reduction either under anesthesia or not. If somebody has had a shoulder out for a while, and believe it or not, I've seen people come in 6 weeks after a dislocation, they didn't know it was out. And how they could not know that, I don't understand. Has to hurt, but some people have come to me that way, and you have so-called chronic dislocations. And that can require surgical treatment, but that's rare. So initially, what do? If you're subluxating or you have dislocated, we are going to send you to therapy. We're going to retrain your shoulder to work normally. Some structures are damaged and won't function well. Others just hurt when you get in certain positions. Some of it's appropriate and the guarding is good, but some of it can cause contractures or things to get tight, and we'll have to retrain you, or more specifically, Jeff may do that for you if he's doing your therapy. It's important. A lot of people don't want to go to therapy, but it does get you back, and it decreases your likelihood of perhaps having to have surgery for something like this. Strengthening the muscles. First you get the motion, then you're strengthening. You're going to stretch appropriately. There's some stretches that can damage things that you don't want to do. And if you're a pitcher or a sports person, whether you're playing tennis and serving overhead, if you throw javelins or something like that, or you pitch, your shoulder has to be aware of where it is as you're using it. And that's so-called retraining. I'll just call it the position sense, proprioception. Now, if that does not work, there are people that we have to operate on, and those people we would either repair a torn labrum, and we do that arthroscopically. If you've dislocated and you have a fracture, we might have to repair the fracture and or replace the shoulder if it's shattered. Rotator cuff tears can occur with dislocations, and as you get older, that's more likely. When you're 20 years old and you dislocate your shoulder, it's rare that you have a rotator cuff tear. When you're over 40, we often get MRIs because it's not unusual to have rotator cuff tears. So that shifts, and in our population, we obviously would see a little bit more toward the over 40 crowd, and we'd be getting MRIs. So you're in a sling again. You have to protect the repair, just like any repair that we do. And again, you're going to work on getting range of motion, strengthening, and you're going to return to sports-specific, exercises that are going to get you back to where you were. There's a thing called SLAP tears, superior labrum anterior to posterior. Orthopedists love these abbreviations, but that's what SLAP stands for. And the superior labrum is this part right here. This biceps tendon, which runs down your arm and is attached to this biceps muscle here, can get torn off by repetitive stresses. It could be attritional, it could be a single injury, and later on I'm going to talk a little bit about the other end of the biceps at the elbow, which is also something we see reasonably frequent. The catching, a locking sensation when you're moving your arm, pain over the biceps tendon, the superior shoulder, you'd notice in this. And this can be hard to diagnose sometimes without an MRI or without going in and performing arthroscopic surgery. So biceps tendonitis, this is the end of this tendon here, right here, as it comes out of the joint. It runs down the arm, and in that sheath you can get fraying or degeneration or just an inflammation of the biceps tendon. And it's not unusual to see that concurrent with rotator cuff pathology, and we do a lot of treatment of biceps tendonitis around here. There can be an instability to the biceps where the biceps pops out of the groove. This ligament that holds it in place can be torn, and if it's torn, certain movements can make it pop out, and that can be just an isolated injury that can be making you uncomfortable, and we'd have to address that as well. Generally, these kind of things, when it's frayed like that or unstable, is probably going to require surgery. And what would the surgery be? Well, first we'll go into the usual treatment: rest, anti-inflammatory medicines, injections, maybe some therapy. But again, if that does not work, we may do something called a biceps tenodesis, where we cut the biceps over here and then we reattach it right here. So it's no longer running in and out of this groove. It still remains attached, but it doesn't run in the groove, and you don't get the irritation from that. On this other side, and this is mostly in a younger person, we would do a repair of that labrum. That's not done as frequently anymore. Sometimes people get stiff shoulders out of this, but in this age group that I see in my practice and who are here, we probably won't do a labral repair like that. We'd probably just do a tenodesis. And ironically, or unbelievably, this does not really result in weakness. The biceps means two, right? So there are two tendons in the biceps. One of them, not shown very well, comes up here. I think that's what they're trying to draw on this picture. and then the other one is over here. So if you lose one of the tendon, your arm may look a little funny, but we don't have to operate on it. And I'll get plenty of people who come in and felt a pop, their tendon is torn, and I'll tell them, you don't need surgery. We're just going to watch it. We're just going to let it recover, unless there's some other injury that makes us do surgery, or if you don't recover and you're hurting significantly. This is something specifically for mostly pitchers, overhand athletes, called internal impingement. As you progress your throwing, your arm stretches the ligaments in the front, and you get that external rotation we were talking about. Well, it stretches the ligaments, and they're prone to damage, but as it also stretches and keeps stretching, you can get impingement of the ball and the rotator cuff on the back part of the socket. And that can result in partial tears of the rotator cuff, labral tears, and you get some instability or looseness in the front of the shoulder sometimes concurrent with that. A lot of these things cross over, and a lot of the shoulder injuries that are repetitive are in baseball pitchers or throwers, but softball or any other sport that requires that kind of stuff. Glenohumeral internal rotation deficit is related, where extreme external rotation, again with pitching mostly, results in looseness in the front, and it limits your internal rotation, but you get increased external rotation, and the tissues in the back of the shoulder tighten while those in the front loosen. And that a lot of times you can treat with therapy, and most of the time you'll get away with that, although occasionally it does require surgery. You can check in pictures. One arm may only rotate down internal this far, whereas this one might only come to here, but the other one's going way back. And so that needs to be looked at, and that's one of the things that we try to train pitchers, kids who are pitching, or throwers, or people who are serious athletes to try to prevent. There's something called the sick scapula syndrome, which is again related to sort of an overuse, where in particular the scapular muscles have to change the orientation of your shoulder blade as you lift your arm up. If I were to hold my shoulder blade down and try to lift my arm, that's as high as I can go. It has to move and rotate with my humerus to allow full motion. And sometimes muscles contract and get tight, and the position of the scapula kind of sits down and rotates forward like this, where the chest muscles are tight, but the muscles in the back are loose. And again, that's something we have to watch for. I won't go into that too much here, and Jeff will probably get on you with that sometimes if you, and I see that in the office. People will come in and their shoulders kind of come forward, and that predisposes you to the impingement that we're talking about. So they're going to get on you and doing shoulder girdle strengthening and working on muscles that you don't think are necessarily part of your shoulder. Prevention is key. Obviously, nobody wants to get hurt and wants to do the sports and things that they can and want to do. So, we pay attention to proper conditioning and techniques, and depending on your sport, there are specific things that can be done, whether you do it with a trainer or you get a formal training, or, some stuff online. Prevention is very important for pitchers, in particular, younger pitchers. We have throwing guidelines. And there's been a lot of attention to that in the past. I know when I was growing up, you could pitch every day, throw every day, nobody would ever rest you. And, they may not make it very far because they're killing the shoulder. There are pitch counts now that at different age groups they recommend, how many pitches per week, how many pitches per game. And sometimes it's hard to get the coaches to pay attention to this stuff, but we and the coaches should be really pushing that. Parents should be behind that too, instead of saying, oh, come on, he's not that tired, let him keep playing. You really want to protect this, and you need to consider at what ages different pitches are thrown. Different pitches put different stresses on different parts of the elbow, and the immature elbow, which I'll get into a little bit, has some particular things that can get damaged when these guidelines are not abided by. However, they can also happen even if they are. So I won't go into too much anymore, but there's tips on kids, and that they should not be playing one sport all year round. You need to cross-train, or you will hear me say cross-train. You can't just keep hitting the same muscle groups over and over and over again and expect them to hold up. So it's important for parents to understand all of that. And we could talk more about that as needed, but you need to have breaks. You need to give the kids a chance to rest. And some kids are real intense and don't want to do it, but you kind of have to force them. So we'll get into the elbow a little bit. There's a number of things that can occur here. Some of them, again, are specific to pitchers or throwing athletes or gymnasts, let's say, but some of them you're going to see here. Tendonitis in particular is a very common thing. Up top is what we would call golfer's elbow or medial epicondylitis. That's on the side here. Golfers, when their trailing arm as they're swinging, can have tendonitis on the inner side, but their lead arm gets it on the outer side, so-called tennis elbow. So you don't have to play tennis or golf to get these things. I could bet some of you sitting in here have had this going on. Just repetitive gripping and grabbing. If you go to the gym and you're on the elliptical machine and you're grabbing, you're contracting these muscles here, and it puts a lot of stress right in those areas where it's circled. This down below is a racket sport, so if you're grabbing a tennis racket, either backhand or forehand, you can have these issues. So that is something you probably are familiar with. What do we do for that? Stretches again. Stretches, strengthening, rest, ice, anti-inflammatory therapy, exercises, sometimes injections for these. The injections may be steroid injections, which decrease inflammation and maybe allow your body to heal and get the pain to go away, or something called PRP, platelet-rich plasma, and that's where we take your own blood, spin it down in a centrifuge. We take the part with the platelets, and that has a lot of complex molecules that incite a healing response, and that's been tried over and over again for tennis elbow. Some good results, some not. It's not a miracle drug always, but it can be something that works, and that is something that we can try if someone is trying to avoid surgery. Last thing is surgery, and where we go in and we actually trim out the degenerative tendon that's been overstressed, if you will. We make the bone bleed, and then that bleeding bone has cells within it, platelets, marrow cells that come and heal and sort of recreate that tendon and allow it to heal. And it's a good operation. It works for an injury that's quite common and often in people is chronic. Ulnar collateral ligament injury, I doubt anybody here has ever had that. That's in pitchers. That is where, again, where you're throwing and you start to accelerate, your elbow is coming forward and the ball is behind and it's lagging. Well, you have to bring that forward. Well, as your elbow is coming forward and the ball is going backward, there's a lot of stress on the ligament that's on the inner side of your elbow. And pitchers do this over and over and over again with a lot of high velocity. You can see how far back this guy's arm is rotated, and that can damage the ligament. First, minor damage, but as time goes on, you're going to get more and more pain on the inner side of your elbow, and again, decreased throwing velocity. People may even feel the elbow sort of shifting, subluxating, I'll call it. And what's going on there is this ligament right over here, the ulnar collateral ligament, which goes from your humerus to your ulnar, gets stretched. And that ligament can, just like an ankle sprain, just like any other ligament, can stretch and eventually fail and not do the job that it was designed to do. That can be reconstructed. These are not done so commonly around here. Simply, we don't have, the population that's pitching at those levels that requires it. It can also occur, I've done them in gymnasts who are on their arms a lot. They put a lot more pressure on their arms than you and I would, and they can get the instability, or they can get a single injury that tears it, and you have to either repair it or reconstruct it. This is the so-called Tommy John surgery that everybody hears about. There's another entity called valgus extension overload, and this is where if you're throwing or landing on your elbow, as you see here, the elbow is forced into a position where the elbow goes this way and the wrist goes that way. That's called valgus, as it's straightening out or extending. And that tends to put forces that are compressive on this side of the joint, the outer side of the joint right here, and stretch the other side of the joint. But it can rub the olecranon here into the humerus, causing bone spurs and a degradation of the cartilage that's in there. And it can cause an abnormal overgrowth of bone. And some of these people can't straighten their elbows fully. Some of you may have been pitchers in your younger days, and you come in and your elbow is arthritic. This is part of what can occur and cause problems. Swelling, pain while throwing, and again, decreased velocity is what symptoms you might notice. Treatment of it: rest, ice, anti-inflammatories, injections, and then arthroscopic surgery can be done where we insert the arthroscope and we're removing these bone spurs that are here on the edge of the olecranon, the medial edge of the olecranon, and also at the tip. Now that can be also done sometimes in arthritic elbows, just as a crossover here that might have nothing to do with throwing. You may just have an arthritic elbow that this has occurred. The immature elbow presents different challenges. Now they have growth plates, the children, and they can get an entity called Little League elbow, where this structure right here has cartilage. As this is growing, the cartilage remains open and eventually fuses bone to bone. But while it's cartilage and while they have those so-called tensile forces there on the elbow, you can pull repetitively on that cartilage and it starts to widen, it hurts, and with a little bit of rest that usually will heal up. But they can also get other entities called osteochondritis dissecans, where the cartilage on the end of your elbow, here on the end of the humerus, can get damaged from repetitive compressive forces. So children, we really need to pay attention to, hence those pitch counts we were talking about over there. Olecranon stress fractures or plain flat-out fractures, let's say if you fall and injure your olecranon, can occur. This is where the triceps tendon comes down here and attaches on the end of that bone. That's the muscle that allows you to push out. If you're doing push-ups, it attaches right back here and extends your elbow. Repetitive stresses to that can result in a stress fracture, or if you fell on the elbow and you can fracture it either non-displaced, where it's like this and it's not out of position, or displaced. The pressure is transferred to the bone, and the bone can fatigue in a situation where there's a stress fracture, where it's repetitively fatiguing. Think of a paper clip. If you bend that, eventually it'll snap. Well, that can happen to the bone if your rate of injury to that bone from overuse is quicker than the body's ability to heal it. Or it can happen a single time where you fall and you just simply overwhelm the bone. And so in this situation, that's a little bit out of place, and that's been treated with what we call a tension band technique, to where you put pins in there with a little wire, figure of 8 wire, to hold that into place. And we do see that fairly commonly. If it's just a stress fracture, rest, ice, anti-inflammatories, remove the offending behavior, as I said, so pitching would have to stop for a while. I've seen it in tennis players from serving a lot, you know, particularly in the youth, but it can occur in adults as well. Here's something we see reasonably commonly. It might not be a sports injury. You may have just had something where you lifted, dropped something, and had a sudden contracture of this biceps to stop it from falling. And that contracture overwhelms the tendon, and that big force results in a rupture of this tendon. So right over here, that tendon pops off. The radius is where it attaches. And you'll see the muscle will kind of pop up and pop up this way. With a long-headed biceps, it will pop down. As I told you, we don't worry too much about that, but the one on this end, there's only one tendon here, and it's responsible for bending your elbow, but even more so, what we call supination, the screwdriver action for a right-handed person. And you won't be able to turn your wrist strongly upwards like this. That generally, hopefully we catch it early and it's caught and repaired. It doesn't do so well if you try to repair it later. The muscle retracts up like a window shade would, but it gets tight and it stays there and you can't pull it back down to where it belongs. And you can see, and one other thing is bruising in here is often there, but not always. This is the repair technique. We go in and make an incision, we drill a hole, and we, over a button, we pull this tendon down into the tunnel that we create, allowing it to heal to that, and sometimes we reinforce it with the screw. Again, that's fairly common. I see that reasonably frequently. Now, I wouldn't call it a sport injury here. Most of the time it's more of an attritional thing, whereas the tendon maybe was getting weakened over the years, and then it finally gives. Wrist injuries, fractures, sprains, and tendonitis are mostly what we'd see in this area. It could be golf, racket sports, softball, pickleball, whatever you may want to do. Even bowling, you get a lot of tendonitis. We'll talk about fractures briefly. very common, always a possible sporting injury. The upper right is a distal radius fracture, we call it, where this fracture, this radius bone is cracked, and you can see the nice line that connects here is interrupted right here. This bone is also tilted from being like this to kind of collapsing. If that's out of place enough, we would end up doing surgery, most likely a plate and screws like you see here, but if it's not out of place, we might be able to just treat you in a cast. Wrist injuries also can be sprains where the ligaments are torn as you've fallen on it, let's say, and you've stretched those ligaments, they can tear. More often than not, we can treat that non-operatively with braces, splints, maybe a cast sometimes, but sometimes surgery is needed for that depending on which ligaments you've torn or damaged. Tendinitis, common, very common. The wrist has multiple tendons going across it. This one is called de Quervain's tenosynovitis, which what we call the first extensor compartment. But there's tendons in there that run through a sheath just like the biceps and the shoulder, and if that tendon sheath gets inflamed, it hurts. And we try to get it uninflamed by removing the offending behavior, anti-inflammatory medicines, ice, stretches, exercises, sometimes injections, but sometimes surgery is needed for that as well, where we release the little tunnel that the tendons are in and give it more space so they don't rub and they're not irritated. I'll just move on to one finger injury that's common that probably you guys have seen. A baseball might hit the tip of your finger, a basketball, I've seen it with fishing even, believe it or not. So there's a little tendon over there that can rupture and let the little tip of your finger, the phalanx, distal phalanx, fall down. And you'll see people with chronic injuries like this, and they can't straighten their finger out because that tendon's been ruptured off, and it either healed in a long position or it remains off, and they'll never be able to do it if you don't treat it early on. We treat these things with splints, like you see in the lower right. If you have a bony avulsion, which you see there, it's called a mallet fracture. The other one above it is called a mallet finger. Those sometimes can be fixed or pinned into place if there's a big piece, but if it's a small piece, you don't have to do that, and you can treat it probably 8 weeks in those little splints holding your finger in an extended position.